Hey, and on This Week in Pharmacy, we have a special segment coming out of news. We had a lot going on. I still want to talk about some of the news, and I held back on some of the clips that I wanted to share with you because of this crew that's coming on next. Not sure if you've heard of these guys, but this is the crew that's running the RX Rated podcast. I'm so excited to be featuring them. I want you to check them out at RX Rated, or I'm sorry, Rated RX podcast. That's Rated RX podcast, and follow them, subscribe. They have some hilarious episodes. And without further ado, I'd like to bring the RX Rated crew, the Rated RX crew. I got to get that in line because of my original Rated RX or RX Rated podcast. So I'm fumbling with that, Robbie.
It's all right. It's tricky. I get it, man. It's okay. It's hard to readapt, so I forgive you, Todd. It's okay. uh,
Hear them
well,
say,
hey guys, thanks for having us. We're really excited to be tuning into TWiRx this week. I'm Robbie Abasi. I'm here with Sam, Llona, and Xavier Hill. As part of our show, we like to just sort of embrace pharmacy culture, talk about big concepts, talk about funny things. But today, I think we're going to keep it a little serious for you guys, and with one of our segments called the Weekly Weigh-In. Sam, please take it away.
All right, thank you, Todd. Thanks for the intro here. So we have a weekly weigh-in, a little clip we like to do on little questions that get sent into us. People want to know pharmacy stuff. So this week looks like we're talking kind of about pharmacy school and ideas of pharmacy coming up. So the question is here, what misconceptions did you have about pharmacy career paths, either clinical, community, industry, anything along those lines, when entering or during pharmacy school while we started? So any initial thoughts that came to mind for you guys?
Robbie, you want to lead us off?
Yeah, as far as misconceptions go, I guess I never really understood what industry meant when it came to pharmacy. I had friends who did fellowships and stuff like that, but I still didn't really understand until they were in the thick of it. Then I realized, oh, hey, this is more research based stuff. But as far as like other misconceptions, your grades, I'll start with that. It is very important to get good grades while you're in pharmacy school, and it's something I still obsess about today. I'm taking a Japanese course, and I was actually just complaining to Todd about this, about, still like wanting to learn and still wanting to get A's, even though it doesn't really matter anymore. But even after pharmacy school, after you pass your residency, if it's something you want to do, it doesn't really matter. And even to get into a residency, that's where it's most important. But once you graduate, I haven't had any employer say, what was your GPA, or have it anywhere on an application that says, what's your GPA? So I can assure you guys, after you graduate is a lot better and a lot easier. So just keep your grades up where you can, but know that no one cares when you're done with school, thankfully.
Yeah, I remember my last rotation having that thought of like, I don't really care about what this grade is. Like, I'm more at this point just trying to learn as much as I can. Like, I want this knowledge, and getting a little bit in trouble because like I wasn't doing what the preceptor wanted, because it's just like, this is just busy work. Like, I don't care. Like, I'm trying to learn this cool stuff that you guys do. I don't care about this grade. And so trying to hit that same kind of realization that you were talking about on those grades
What do you think about residencies, though? Do you hear that a lot at all, doing residencies?
and grades needed for it.
I mean, just like needing to do residency after school.
So my first thought on this question, just related to that, was I'm pretty sure it was in Tillman's class, so something that we were doing, and that first year, always hearing about residencies, and like, this is kind of like not necessarily what you're looking for, but they just keep bringing it up over and over, and what this thing is, and wanting to do this, and whatever to get into this specific residency you want cardio, you got to do this. And I remember writing in some response being like, okay, like, I guess I need to go into residency. Like, I didn't realize that going in here. But I guess this is how you have to proceed to be a pharmacist. And I'm pretty sure it was Tillman, and she, bless her heart, was just, responded back to it in the message. Just like, hey, like, I understand, like, that's what it sounds like, but believe me, most people are not, in residencies or community. It's completely fine. It's where, most people are, and like, there's no issue with that. And so it felt that kind of swing of being like, I guess you have to be the top 10% of your class or else you're completely useless. And then
Yeah.
uh, someone being like, no, that is not true. That is not how this works. And going through that transition. Luckily, I think it was our P1 year. So, there wasn't too much of that stress going on.
Yeah, another thing that is a big misconception as well is I remember going through the skills labs and they had all these mock patient counseling sessions where you had to say so much, make sure you hit all these points. And while I was very grateful or it made me comfortable talking to patients, realistically, you don't have that much time to talk about all that stuff. I mean, in my setting, I am a little luckier because I'm like in a hospital and it's literally my job to make sure they understand and go. But when I was in community, people didn't care. They just wanted to know, like, hey, do I take that with food? Do I not take that with food? And they'd be on their merry way. So, because you have like a million things you're juggling. So, I think while you're in school, spend time learning everything, learning the side effects, learning the main counseling points. You should know these things. They're going to ask you these things, but you might not have time to discuss all these things. So, it's very important to know how you know how to manage your time and then give the patient what they want, what they need at the time. But don't beat yourself up if they don't want to hear everything you got to say. So just that's a big misconception. I think I realized out of school pretty quickly.
Nice. Yeah. It's a lot to like a lot of stuff we don't know about pharmacy going in, especially as a student. If you weren't exposed to it, you probably didn't know a lot. I know me, I originally wanted to do community or independent pharmacy because that's all I knew. And I recently went home this past weekend. And I went home to look for my Pokemon card. Well, I went home for homecoming, but
Pokemon cards. I heard
I
Pokemon
I
cards.
went to look for my. I wear Pokemon cards. I had some old Pokemon cards, and I was like, I wonder if I'm going home for homecoming. I wonder if I still have those. I couldn't find them, but I did find a old journal where I had to write essays and for English class. So back in 2010, 10th grade, I found a journal article or essay for my English class. It was like, where do you see yourself in 20 years? And I literally wrote out my entire life right now as it is, minus the hospital part. But I was like, I'm going to be a pharmacist and I'm going to own several pharmacies all around the world. You know,
Let's go,
I
baby.
really thought I was going to be an independent pharmacy owner and just have pharmacies all over and be a billionaire by now. That didn't quite work out, but
A few more years.
I did become a pharmacist. Yeah, a few more years, right? Maybe with the podcast, we'll take over.
Mm-hmm.
But I did actually become a pharmacist because at that time I didn't know that pharmacy was so diverse. I didn't know they had industry pharmacy. You can go into the hospital. You can be a public health pharmacist, managed care, compounding. I didn't know all that existed. I just thought it was just regular community pharmacy. You come get your meds, give them to you, put it in the bag, and then you're on your way. So it was really cool to look back and see like what I thought pharmacy was at that time. So after going through pharmacy school, I did different rotations and tried out different things. I really fell in love with the inpatient hospital side of pharmacy where you could work with the doctors and talk with the nurses and really do more high level stuff and manage heparin drips and dose complex antibiotics. I really enjoyed that part of it. And yeah, it was totally different than what I expected. So it's probably a lot of misconceptions out there until you really get into it or really do your research on it and figure out what it's all about.
That's so hilarious to say that because I also wanted to own a pharmacy and I initially did my PGY1 in community pharmacy and I selected this pharmacy this PGY1 because they were like, when I interviewed, they're like, yeah, we'll teach you how to run a pharmacy. You'll feel good. You feel competent. And I was so excited. And I remember like my first day actually meeting, not with the residency director, but the director of pharmacy who was in charge of like 20 some stores. I remember he looked at me and he said, do you really think you're going to be making a lot of money owning a store? And I was like, what do you mean? Like, I want to own a pharmacy. I want to be my own boss. He's like, no, I think
No,
you
you don't.
might, yeah, like I think your mind's going to be different by the time it's done here. And so I was like, okay. So I had a misconception as a student here. And while the residency was great, it prepared me, but I eventually became a manager at a little independent store where now I got to see all the bills and transactions, the things that I couldn't see as a pharmacy resident. And I remember hearing the owners complaining about, not getting enough money, these kickbacks, like, oh, or what are we going to have to cut? We're going to have to cut hours. I remember thinking to myself, like, I don't want to do this. This is a nightmare. I don't want to be worried about like, can I keep the lights on this month, or how much, and they sold alcohol, they sold beer, but how much beer am I going to sell so I could, just be afford to buy something expensive medication to keep it on the shelf when it's needed. And that's when I learned real quick, like, you know what? I don't know if this ownership thing is for me. I'd like to pursue it, but unfortunately it's just, as we talked in other episodes, it's sort of controlled by these big corporations and PBMs that play a little foul and dirty. So thank God I'm somewhere else now,
Boo.
but definitely a lot of misconceptions. Yes. Hey, Todd, you got some feelings on that. I heard someone say boo. Is that you, Todd?
Yeah, that was actually Sam booing, but I
Sam booing.
agreed with him. Um, bane of the bane of our pharmacy industry is the three biggest PBMs controlling 82% of all the prescriptions.
82%. Wow.
It's just crazy. It's just crazy. But hey, talking about the future, and I have a chance to meet with WVU Pharmacy P3. Shout out to the P3 class of W. But I go down there and talk with them, and it's a tough love presentation where I'm talking about what's really happening in the trenches of specialty, community, hospital system, entrepreneurship, artificial intelligence impact, policy, politics, wokeness. Just I kind of like roll it all up into the real world, and we have a ball. It's been my fourth time to share with them and get a lot of information that they might not get from someone who's been, you know, 22 years now observing what's happening to our profession, and how pharmacists our roles are changing. And your imagination, leverage of ChatGPT and the use of AI to assist you, and acceleration of data and study. I mean, it's a new age in being a pharmacist, but it's not an I don't see it as a negative. I see it as reinventing what the pharmacist was kind of always supposed to be, and driving things without it always having to be connected to a dispensing fee. I think pharmacists in my living future, I got 25, 30 years left in work, and I think I'm going to see it when pharmacists are primarily paid as providers and clinicians, and not by the dispensing fee. I think the dispensing fee model has run its course.
Yeah.
Like with the PBMs going right now, that's just squeezing that more and more
True.
that Robbie was talking about.
Yeah. Another misconception, and I'm so glad you brought this up, is AI. I hear a lot, especially online, like, is AI going to take over your job? And I know we had this, conversation about this in the episode that you featured on our show, Todd. But, speaking as someone who works in the career actively using AI, I think we're all guilty of this. Sometimes you're doing a CE and you're like, I don't know the freaking answer to this. And, you pop it in just to get an explanation, and they'll still get the dang question wrong. So I'm just like, okay, clearly AI isn't getting this clinical sense that I'm not getting either. So I don't know if that's a good thing. Neither of us getting it at the time, but it can't do that job. So I wish, as a student, though, I did have AI available, not in a sense to like cheat and like get answers and write my papers, but now I use it to help me study and do CEs. Like, I can't tell you how many times I'll take the PowerPoint that's just like this big old file. I'll pop it in and say, can you organize this for me? And it spits out a study guide for me. And I wish I had that, because I can't tell you how many late nights I spent organizing it the way that still didn't make sense to me. So I don't have the best handwriting, so I wish I had AI at the time.
Yeah, I would have definitely used the AI to study for sure. I would have had it like, all right, quiz me, ask me like, here's my questions, quiz me, and I would have been going through it like, how can I get this right the next time? I got it wrong, let me know, and I would have been running my ChatGPT bill up for sure.
Yeah, yeah. Well, I don't know, man. If it's quizzing you and it's still wrong, I don't know if you can trust it.
Well, I
So,
mean, I'm gonna use the correct information, like
yeah,
like give it a screenshot from the book or something.
yeah. Have it spoon feed you the information. I think that's the best way to use it. Have it spoon feed and organize your information.
It's getting there. It's getting there for you. So then for rotations, or I guess in general, anything that you guys had that an instance, moments, assignments that made a difference for you, for these students, that might have also been a misconception versus it being didactic versus your more clinical experiences you guys had?
One rotation that stood out to me, and this was actually something I was considering as opposed to doing community, is what I'm actually doing now, working in mental health. So I remember doing this rotation, and everyone saying like, "Oh, it's really cool, but you have to be very, very careful. You're working in public health. You know, you got to worry about your not public health, but psychiatry. Got to worry about your safety." And there were some times it did feel a little maybe scary, but it was such a good, meaningful rotation because I got to see people come in disheveled at their worst and then leave like at their baseline best self. And that was just such a rewarding experience. And that was something I wanted to pursue, but in my head at the time, I was like, no, I want to do community pharmacy and I want to own my own pharmacy. And so I was a little hell bent on that. And it's just so funny how life works because I got that experience and it inspired me. And that's what I'm doing today. So my little tidbit for students is really engage in your rotations there. You might have your one set goal to do one thing and life might take you a different way. You already have your experience doing it prior and you'll have some sort of sense of what you have to do to make that permanent. So really enjoy those experiences, do as many as you can and yeah, just go from there and go grow.
Nice, nice. Yeah, I totally agree with that, Robbie. Just really experience it and kind of go from there. For me, a big misconception from going from the classroom to clinical rotations or going to your job is the communication. You think the time and communication, right? So you think you have time to sit and go over this whole article or present this whole presentation to the doctor, where the doctor like, all right, give it to me in 10 seconds. Tell me what you want me to know in 10 seconds. Like they don't want you to sit there and talk to them all day. So you have to figure out how to communicate effectively and deliver the information. And same thing with the patients. You have to be able to deliver all the knowledge that you have and like break it down, dumb it down for them to a way that they can absorb it so they can understand what to do with their medications, side effects of their medications, how to take their medications, and also do it in a decent, small amount of time. Sometimes they don't want to sit there for counseling for 30 minutes. They got to go, pick up the kids from school or something, or they got to go take care of their grandmother or something. So, like, you have to be able to communicate and deliver all your information in a small amount of time and efficiently once you get out of the classroom and into the actual practical setting. So, it's something that can be a misconception that you have enough time to actually just deliver a large amount of information.
Yeah, time's limited for sure. I guess mine related to that communication is maybe the first time realizing, you can really only control what you can control, and the patients are going to do what they want, and they're not going
No
to
kidding.
listen. They're not going to listen to you on some things. And what came to mind was being in hospital and essentially someone leaving against medical advice or medical care, and they were pretty serious, had a serious bacterial infection. They didn't want to be treated. The whole team going down to the front and like the U-turn in front of the hospital and trying to like talk to him, and the resident, the attending are all there, and I was like standing further back, but they're like, you have to take these antibiotics, you have to stay here, like you are not going to make it for in the next week or two. And him in a wheelchair pretty much rolled down the end of the block, like wouldn't listen to him. Finally the family came over in their minivan to load him up, but he was just adamant. It's like, no, I'm going home, I'm not doing this. And regardless of how good the medicine was, how well the team was able to decide what they needed, how to help them, at the end of the day, patient didn't want it, patient wanted to go home, and that's what happened. And I think realizing that you can only do so much, and you got to be, at some point you got to be okay with that it's not on you for that situation.
I bet the guy just wanted to die in his bed, honestly. Like that sort of thing. It's like, because there are a lot of emotions that go on when you're sick, and you're just like, no, I will not die in this hospital. I will die in my bed. So I part of me wonders, man. Part of me does wonder.
Possibly.
Maybe
Or you just wanted to go home, feed his dog, and then come back the next day.
Yeah.
I
It's just-
just want to die in my bed making love to my wife. That's what
That's the way to do it.
That's
I
all he
mean,
wanted.
you can make that happen anytime, Todd. If you think about it.
but I'm not old enough. Like I want to be like 102 or something like
It
that.
doesn't have to be
There you
age,
go.
though. It could be an accident. An accident.
Accent.
Yeah. You got a good life
Romeo
insurance
and
policy?
Juliet.
Hey, I want to shift gears on you guys because something's been bothering me this week, and it started with this post. So I'm going to bring this up from Instagram.
Uh-oh.
Oh,
Is
that's me. What's up?
you talking about our horrible, absolutely horrible political climate that has impacted healthcare way, 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 way too much, in my opinion, and how it's gotten like that based on the sickness that is social media. As wonderful as social media is, it's also, um, it's also in some ways very horrible. And it just and so there was a follow-up post around this subject of politics from a very good friend of mine who is known. His name is Matthew Zachary. He's the founder and a survivor of Cancer Sucks. And he now runs a podcast, enormous podcast, hundreds of thousands of listeners, called Out of Patience with Matthew Zachary. And he posted on LinkedIn a really good post that goes down into the whole element of why in the world are we experiencing measles again at a time when it was supposed to have been eradicated? And when you start drilling down in through the data, you find out that people are not, vaccinating their children for measles, and it's like it's popped its ugly head up again. And I think that in of itself in 2025 is absolutely horrific, and it shouldn't even be a thing, and it frustrates me. With that, if someone's to listen to that section of my rant, they may think, oh yeah, this guy's, he's woke, and he's all liberal, and he's
See,
really
but
pro.
why is good health policy woke? That doesn't make any sense. It's such a stupid labeling. It's so dumb. This is what I hate about politics. Sorry, Todd. It just really grinds my gear that a good health policy is a woke policy.
It's not. So the whole post is when I made a comment, I called out, and it upsetted some people, but I called out the system, and whatever we call the system lost the public's trust. It wasn't the public that's all to blame for this. It's not Joe Rogan. It's not Donald Trump. It's not. It's a cultivation of ranting and of cancel culture and all this stuff that has kind of bubbled up to the unfortunate of where we are today. And I want healthcare providers to call the system out and say, during the pandemic or during this time when the opioid epidemic was having, the systems, the FDA, the CDC, these organizations that are supposed to protect public health betrayed public health to make money or to advance an initiative. And sure enough, the public's trust started to disintegrate. And then, of course, you pour gasoline on that with social media and with, crazy HHS directors that don't have PhDs and or an MD, or that are running the whole country's health and human services. And I'm standing there kind of in the middle of it all. Like, I'm not on this crazy radical side, and I'm not on way on this, and I'm standing where I think the majority of everybody is standing, kind of in the middle of it all, and saying, like, this is really, really effed up. Like, it's really jacked up.
I totally agree.
Yeah, I think people got hurt. I mean, you can say or point to one thing. It's like, scientifically, yes, this is wrong, but obviously there's a lot of people there listening and believing, and it kind of, as you're stemming, it came from someone getting hurt, prices being higher, couldn't afford something, didn't believe in this, whatever it might have been. They're hurting from something, and they hear this voice, and that's what they end up following. So, we having more science background than most people, know that there's some serious holes, some serious problems in what's being said. But there are so many people that are, they're looking for that help, and this is what they see. And so, as you're saying, it sucks from a science standpoint. It sucks that this measles coming back. We're not hitting those 95% cutoff rates for vaccines for herd immunity. It's just continuing to cause problems for people, and we got to get that trust back, and it's not going well.
Very much so. Agreed. Agreed. I have a book that I'm reading now, and it gives kind of like credence to the whole trust factor. And when I think of pharmacists, I think of trust, because you're the most trusted healthcare providers out there, more than. So this is a book by David Hardsager. I'm sorry to mess up his name. Horsager. Anyway, so he's the CEO of Trust Edge Leadership, and I got to see him talk at a conference. One of our clients, Framework LTC, pharmacy software system dedicated to long-term care, and during their user conference, got to hear him speak on how important today trust from our providers is more than ever because of these fractions and because of these cracks in the stage of healthcare in the United States that we're in, not only from the payment perspective, but also from the delivery perspective, and how our physicians and pharmacists and nurse practitioners, they're held hostage to systems, and they're held hostage to big insurance providers, and they're held hostage to elements of the business of healthcare that have no business standing between a patient and that provider. And that's part of that trust element that we got to get back. We have got to get that back.
Yeah, and unfortunately, I do think it's gonna get worse now that this political shift has now become like, "Hey, you guys took money from us, we gave you grants, we want a stake in your company." And that in itself is a little scary because now you could theoretically have the government direct a company to do what they want them to do, and rather than a company pursue and seek science. So I do fear the how things are gonna look in 10, 15 years and see how politics are going to play a role in directing a company to do one thing over another. Hopefully, they will re-earn the trust of the public, not just healthcare providers, but, politics. But I don't think anyone will ever trust a politician. But that's another rant for another day. But yeah, I'm just worried, because we talked on a show before our last episode, the thalidomide tragedy, right? Like the big crisis that was averted here in the United States because Dr. Olden Kelsey basically was like, no, I'm not approving this drug. And this company multiple times tried to get this drug approved, and she kept saying no. Meanwhile, in Europe and in Canada, they started having these malformation in babies, but that was largely prevented in the US because they listened to experts. And now, because of this political shift and no one wanting to do it anymore, we have these raising rights and measles. And unfortunately, it's now becoming socially acceptable to be like, yeah, measles rates, ha 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 ha. It's like I think that was at the post that you pulled up about the betting. I don't know if that's the one you pulled up, Todd, but I was just so blown away because I was on this app, looking at random bets just to, goof off. And I saw this post that was like, hey, do you think there'll be more or less than, I think it was like 1,900 measles cases by the end of the year? If you put in $100, you can make $150 if it goes one way. And I'm thinking to myself, like, this is really effed up. Like, we're literally betting on sick people right now. Like, it's like we're so desensitized to this, and it's screwed up. Just very, very screwed up. But what are you guys' opinions on that? How we're desensitized to these things these days?
Yeah, well, first of all, the US is just full of degens and gamblers for sure. So we'll bet on anything.
Yes, yes.
But yeah, we're definitely desensitized to, it's hard to know what's right and what's wrong. So we need more people out there that, giving the research and the education and just explaining what's important for us to follow health wise, versus just, getting all your information from TikTok or
Yeah.
Joe Bud from up the street. Right. So it's hard to really just get good information out there. So they need podcasts like ours and other podcasts on the Pharmacy Podcast Network, and reputable people out there just giving out the good information so that everyone can kind of know what to do and know what's right for our health and build on that and go from there and regain the trust.
Yeah. I do think there's some pages that you could follow, though. There's one particular page on TikTok I like called, I think it's Dr. Anti-Hero, and he literally calls out other healthcare professions too, specifically chiropractors. This guy has a vendetta against chiropractors, let me tell you. But he'll like pull up a paper that they think they're referencing and just like, but it's just like, while it's entertaining, it's sort of like, yeah, we should correct them, but I think you should focus your efforts on the politicians here because they're the ones who are the ones with power and actually impacting our health as a country.
Yeah, there he is. On the
There,
screen.
yeah, that's the guy. Yeah, he's a good one to follow.
Yeah, I think I've seen him before.
Yeah.
But like when last time we were talking with Todd going over this online stuff, it's fortunately or unfortunately goes down to the user and what they want to look at, what they want to believe. So yes, trying to get all that out there, but it's tough when it doesn't really matter what you say if they're not caring.
That makes me think of something else too. Like, a lot of AI videos are out there, and people who don't know any better are believing, certain AI videos, and they got some good ones out there that you can't really tell that well. Usually, I mean, because they usually use the same font or sound right now, so you can kind of pick up a lot of it. But AI is out there just making up anything just to get likes and views, right? So they can make up a fake story about spider bites that give you superpowers and turn you Spider-Man and got people flying
Sign me up.
around, right?
Well, Todd, that's when Todd's going to be a millionaire with this little token of human content.
A certification. There must be a certification out there that
To say this is not AI.
AI driven. Like there needs to be a law that says if you develop content it's purely AI, you have to tell the public this is AI, as well as news organizations. I've said this for years. Now I sound like the old guy. I've said this for years.
Back in my
Come
day.
on, Grandpa.
That if CNN or Fox has a commentary show, it needs to say like commentary opinion or editorial opinion as a post instead of calling it news, because news was Walter Cronkite back in the 70s, and back when news was black and white, it was news, there was no opinion. We need to educate the public that there's a difference between a talking head and that's not news from Fox or from CNN or from any of these, The View, for God's sakes. If you're calling it news, or if you're calling it, evidence-based medicine, or if you're calling it content that's AI driven, we have to label that stuff just like you label a medication and the safety of medication label.
Well, I got a question for you, Todd. So let's say this does exist and there is a label, AI versus human made. Going back to us distrusting, politics and how it's so politicized and left, right, whatever the heck you want to complain about. We won't get into that either. But with a labeling like this, I personally think it's going to be abused by our politicians too, that we don't trust. It's like an AI video could come out to slander someone, but someone in control could be like, nope, this is real, or this isn't AI, when really it's AI. So I don't know. It just goes back to that public trust, and I would like something to be like that, but my tinfoil hat, and I always talk about this. My tinfoil hat just doesn't trust that something like that too. I want to believe it, but I don't know. I just don't trust our government. I think it's good, regardless of who's in control. It's good to have a healthy distrust, whoever's in power.
Just a little bit, huh?
Just
Kind
a
of
little
like
bit.
anxiety. You just need a little bit.
Yeah, exactly.
We have the solution. We just have to trust Skynet. Skynet.
They'll make all our choices for us.
Full circle.
Yeah.
It's like not too bad of an idea.
Yeah.
Tried everything else. Why not? Screw it.
This is awesome. You guys are doing an amazing job. Once again, Rated RX podcast. You can find them on all of the feeds. And of course, we are excited that you're coming to the Pharmacy Podcast Network. We're going to be distributing starting with episode 30. And we're going to have a little celebration of the 30th episode of the Rated RX podcast as well. You guys, you got to keep it going. The number one way that a podcast is successful is the consistency. And that's the number one indicator for success in podcasting. So keep going.
Should.
Yeah.
Let's go.
No matter how much you want to cry, keep going.
I've cried for 16 years.
We can have an episode where we all just cry,
Don't threaten me with a good time.
We can invite
right.
pharmacy students.
Exactly. Shout out to pharmacy students. You guys are crying. You're going to be in $250,000 worth of debt.
Now I'm actually going to cry.
All right. That's it for this week in pharmacy. Once again, RX Rated Podcast. Shout out. We'll see you guys soon.
Bye.
Peace.
Thanks for having us.